So good afternoon, everyone, and thank you for joining us. My name is Steph Kershaw, and I am a postdoctoral research fellow, Tilda Centre for Research in Mental Health and Substance Use, which is located at the University of Sydney. And I'm also the project coordinator for the Cracks in the Ice online toolkit. I'd like to start by welcoming you to today's session, and just to let you know that as this is a webinar, all participants are in listen-only mode. So this means we can't see or hear you, but please do send through your questions through the Q&A button on your dashboard. We will be recording today's session, and the recording will be made available to you to download within the next week. So as you are probably all aware, today is the second of a two-part webinar session on the topic of current and promising treatment options for ice dependence. So 2 weeks ago, we heard presentations about how ice affects the brain, the current cognitive and psychosocial treatments that are available, and as well as the latest research examining possible pharmacotherapies for ice dependence. So today we welcome back our three experts. We have Professor Martin van der Buuse, who is a Professor of Neuroscience at Trobe University, and his research studies are focused on the role of brain systems in psychosis and addiction. So welcome, Martin. We also have Professor Frances Kay-Lambkin, who is internationally recognised for her innovative technology-based interventions for mental health and substance use disorders.
Hi, everyone.
Joining us. And we also have Dr Shalini Arunogiri, who is a clinical lead at Turning Point, as well as a consultant addiction psychiatrist. And Shalini is the study coordinator and medical advisor to a range of current clinical trials of pharmacotherapies for addictive disorders at Turning Point. So welcome, Shalini.
Hi, thanks.
So as you are probably all aware, today's session is to answer any questions that people have about treatment options for ice dependence. So we have received a few questions prior to this session, and we'll get started with them today. So first up, Shalini, what is the pattern of use that is considered abuse?
So that's a good question. I guess the term abuse has been used to refer to people who have problems with substance use, and the terminology in relation to substance use and substance use disorders has changed quite a bit over time. So terms like abuse and dependence were largely drawn from the classification system for psychiatric disorders, the DSM, the Diagnosis and Statistical Manual. And so that's moved from a version 4 to version 5 in the last few years. And so traditionally, where we used to refer to terms like abuse and dependence, nowadays the current terminology is substance use disorder. And I guess the difference now in the terminology is that previously, when we used to refer to someone having a substance abuse pattern of use, abuse sort of reflected a range of problems that someone might have, but not perhaps the full spectrum where they might also have difficulty stopping the use of the drug. In particular, physiological problems like needing to go into a detox center, for instance, to get some support around their withdrawal symptoms, etc. That sort of symptom presentation would be considered consistent with dependence. Nowadays, within a substance use disorder terminology, we consider a whole range of different difficulties that someone might have with their substance use. So that pattern of use would encapsulate, for instance, people who might be using occasionally but still experiencing problems, all the way to the extent of someone who might be using every day and still having some problems with withdrawal, for instance, and might need a detox. So all of those symptoms are now encapsulated within a term called substance use disorder.
Okay, great. Did you have something you'd like to add to that, Frances?
I would, if that's okay. I think for people out there who maybe don't have access to the diagnostic tools that we do as clinicians working in the area, the patterns of use that we would start to be concerned about are those that make the person more likely to do things that are involved with getting the drug, getting crystal meth, getting ice, using it or recovering from its effects. So the more time a person is spending on those activities as opposed to other things like studying or working or contributing to the family or spending time with friends who maybe are outside of that use circle, that's the point at which we would start to suggest that some intervention or some treatment is really warranted. So And that's how we, I guess, operationalise some of those diagnostic criteria. So if it's impacting a person's social relationships and functioning, their occupational relationships and functioning, and their health and well-being, and they're not spending as much time on those sorts of things as they are on using the drug or recovering from its effects, that's the point at which we start to get a bit worried.
Okay, great. Well, I think that's a really good explanation. Thank you both, Frances and Shalini. I have a very specific question for you, Frances, and it's about the ICE modules that you introduced us to in the webinar. And so someone was wondering if the Breaking the Ice modules have an audio option for people with low literacy.
That's a great question, and the reason it's great is because the answer is yes. So it's not a perfect option, but it is a plugin that we have just put into the online program that enables a person to listen to the text on the page rather than having to read through the text on a page. And what it also does the text to be interpreted in presented languages, both in the written form and in the audio form. So stand by, that should be available to use anytime within the next month.
Excellent, that's great news. So Shalini, I was wondering how difficult is it to medicate someone who has recovered from ICE dependence if they have ADHD? So I know that dexamphetamine is one of the medications that's used to treat ADHD. Is that a problem if you give it to someone who has ICE dependence?
Yep, so I guess the question relates to something that from a diagnosis perspective can be quite complicated, both from a mental health point of view, but also for the person who's trying to understand what's happening for them when they're trying to quit as well. So I see lots of people who are in the context of currently using methamphetamine, are trying to understand whether ADHD is something that's a relevant diagnosis for them. And for many people, they might not have had the opportunity to follow this up as a young person or in school or as a teenager. So later in adulthood might have a lot of problems with attention or their memory. And might be presenting in the context of currently using substances such as methamphetamine. So I guess the first point to make there, I guess, is whilst the person's still using methamphetamine, it's very difficult to be able to tell whether there is an underlying diagnosis of ADHD that's relevant. This can be for a whole range of different things. When you see someone in adulthood, it's really hard to make a diagnosis that may have originated in childhood. So just on the basis alone, that can be tricky. But we're often making those diagnoses based on how the person's presenting as an adult. And when you're using methamphetamine, particularly if you're using a pattern that's a dependent pattern where you're having sort of withdrawal symptoms fairly frequently, the withdrawal symptoms from methamphetamine can look a lot like ADHD in itself. So in terms of having difficulties with attention, thinking, concentration, memory, etc. So in the context of using regularly, I think the diagnosis can be virtually impossible to make for many people. The next question is then, for instance, if someone's actually stopped using and is in that early recovery period, about trying to understand whether a diagnosis is relevant, and if so, whether medication treatment is indicated. Again, this is a complex question, and it can often be driven by, I think, an individual and their current presentation in terms of what's happening for that person at that time. Are they wanting to achieve particular things if they were on medication, for instance? So for some people, that might be getting into employment or engaging in any sort of relationship, etc. So it's trying to understand if the medication was helpful in this phase, what would it actually be helpful with? I think the question that's being raised is also perhaps a question around tolerance, possibly. So if someone is using methamphetamine for a long period of time, they've been exposed to a high dose potentially of a stimulant for a long period of time. So then when you go into to treat with another stimulant, many of the stimulant treatments for ADHD include things like dexamphetamine or methylphenidate, for instance. The question there is whether the same doses of medication might be as effective. There's no kind of cut and dried formula here, and I guess for a lot of people, how much they're using in terms of methamphetamine can be different as well. So some people might be using larger amounts every day versus other people might be using once a week. So I think this really highlights, I guess, the complexity here, highlights the need to be able to find someone that you can see as a psychiatrist who understands what's happening, to work through some of these issues and to try and understand if medication is being used, what it's being used for, and where to actually intervene if it's not really being helpful.
Yeah, wow, that does sound really complex. Just from a pharmacological point of view, Martin, what are the sort of similarities between common ADHD medications and methamphetamine? Do they act on the brain in a similar way, or are they different?
There are actually a lot of similarities between the two types of drugs, and they do indeed both affect the dopamine system in the brain. It's just that the psychiatrist, the doctor, the treating doctor will always make sure that the dose is controlled, that all the other conditions are stable. Methamphetamine use is, of course, very different from a controlled clinical environment. Most importantly, though, methamphetamine differs from some of the other amphetamine analogs in the way it works. It's even though it may have the same target in the brain, it reaches that much quicker, and therefore has a much more sort of immediate and strong effect. And Shalini can correct me if I'm wrong, but in the new trial that is about to start, that she mentioned in her talk about lisdexamfetamine, that is actually a drug not very dissimilar from methamphetamine, but it's much slower to act, and thereby sort of takes away the urge to take methamphetamine without having necessarily the damaging side effects. But I'm happy to let Shalini finish that little story. But yes, there is a definite overlap, and that's why the question of ADHD and meth addiction came up, of course.
Yes. Frances, is there something that you would like to add to that?
I was just going to ask a question I think that Martin has answered, and that is there a risk that someone who's previously been a meth user and might be commencing a medication related to ADHD, is there a risk that it would, I guess, put them at high risk for taking up the meth again? But I think you've possibly said that potentially no.
Shalini, did you have any response to that?
Yep, so I guess, I mean, it's, we know that anyone with a history of ADHD is at a higher risk long-term for developing a substance use disorder anyway. So it's just about, keeping vigilant about that, I think. And if there is a relapse risk, I think, being aware of then having kind of, people you can check in with if that does happen.
I can add maybe something else, and that's that conditions like ADHD, drug addiction, or schizophrenia are, of course, not all about dopamine. There's a massive range of other chemicals in the brain that modulate the effects of the dopamine system, and that's where major differences between the conditions exist. It also means that, because otherwise, is ADHD, is psychosis associated with ADHD? No, not really. And yet, there is a central role of the dopamine system. So what might have occurred in my presentation last time is that it's all about dopamine, it's all about dopamine. No, but later in the talk I did mention that there's a whole lot more happening, and it is those other systems that modulate the dopamine system that determine where a person might go, where genetics kick in, for example, but also where medication might be helpful rather than to target the dopamine itself, the system itself. It could be those other systems, say glutamate system, for example, that have a strong modulatory action on the dopamine system to get a person off the meth, keep them off the meth, or in other cases, it's got nothing to do with meth, but you're talking about ADHD. I think the ICE trial that is going on, and again, that's not my specific field, but it is a good example of a drug that most likely doesn't have an effect directly on the dopamine system, but it's very good at doing an indirect modulation of dopaminergic activity, and may therefore have a very beneficial action in meth addiction. But again, Shalini, maybe this is where you should take over.
Yes, I think that's exactly right, Martin. I think that's where, I think we're looking at pharmacotherapies for methamphetamine use. We're trying to, lots of different trials have tried to come at it from different directions. I think many of the trials have looked at stimulants that act largely on the dopamine system to try and see if that's a replacement, really. And then you've got other systems that are implicated, like Martin mentioned, in terms of glutamate systems. So there are other medication trials, like the NICE trial, really about supporting that modulating effect, that inhibitory effect, to try and see if longer term that can help support that recovery process. So it might not be all about just looking at, say, for instance, when we look at methadone and buprenorphine treatment for opiates, we try to look at something that's, exactly going to come in and replace over what the opiate is that the person's using. Here, that's been, as we talked about the last time, less successful in the methamphetamine space. So it's looking at whether lisdexamfetamine might offer one option in that space, but whether there are other systems that we can kind of support from a medication perspective that can keep the person going longer term as well.
And Shalini, is there any testing on the addiction liability or the risk of developing addiction to lisdexamfetamine?
Yeah, absolutely. So one of the really important things that was a feature of understanding whether this is going to be a good medication to trial was to look at lisdexamfetamine's abuse liability. And part of these abuse liability type studies are done very much in a clinical experimental setting. So within a lab setting, trying to see if the medication is administered, whether people report subjectively liking that drug. So that's part of that abuse liability potential. And then the next step is also understanding that in the community, if it was used in a trial, for instance, what's the likelihood that this might be potentially injected or to be sold on? So used in ways that are different from what you've been prescribed that for. So with lisdexamfetamines, we've talked about, because it's a longer acting medication and it lasts over the course of the day, it's slower to get to that onset effect, and also because it needs to be actually taken into the body to be converted into its active form within red blood cells. All of those reasons mean that abuse liability is less than something like, say, dexamphetamine or something else that's immediately converted. So that gives you a few options in that space.
Okay, great. So now we've just had another question come through. And so this person has noticed a trend of prescribing opioid treatment for people who use methamphetamine as their primary drug of choice. So does anyone know why people are prescribing opiates for people who use methamphetamine? Shalini, have you come across this in any of your work?
Yeah, so I can chime in, and maybe Martin might want to chime in as well in terms of some of the mechanisms here. But I guess from a face value perspective, one option is that opioid treatments can also act in the reward system that are triggered by, commonly by many drugs. And so some of the potentially trialable treatments here, things like buprenorphine, for instance, or Suboxone, that have been trialed in some trials overseas, in particular for people who are struggling with methamphetamine use, with mixed results. I think here what I think is important is it's not necessarily a medication that's coming in and treating exactly what the problem is that the person has, where their primary drug is methamphetamine. But I think the other thing to think about is when someone's using methamphetamine, we know that the vast majority of people who seek treatment and who have problematic use often use more than one substance at the same time. And within that polysubstance picture, opioids can play a role. And so, for instance, if the person is using an opiate occasionally, then there might be a role of trying to use something like that to target the reward system as well as treat the opioid replacement.
All right, cool. And Martin or Francis, is there anything that you would like to add to Shalini's response?
No, I don't think so. No.
No? Shalini, you did such a good job. So I also wanted to quickly talk to the three of you about common comorbidities that can happen at the same time as ice dependence. So roughly how many people present or have mental health issues when they come to seek treatment for their dependence on ice? Perhaps Francis, this might be a question for you to start off with.
Absolutely. Well, Shalini's also mentioned that there are often other substances that a person might be using in addition to crystal meth. Maybe we can talk about that a little bit later. But the reality is that it's upwards of 85% of people who access treatment for crystal meth use, but also any drug use, will actually often be experiencing a comorbid mental health issue at the same time. And so we also know that it's not only mental health comorbidities that commonly co-occur with crystal meth use, but there can be some real physical health problems that emerge. And what I think is really important to understand, so those the mental health problems are things like depression, anxiety, we've talked about ADHD, and particularly traumatic trauma and traumatic experiences, particularly a young person, can often be behind some of the reasons why people start to use, particularly as a way to help them I guess, navigate through all of the emotions and the symptoms they experience as part of those early childhood experiences.
Yeah.
What's important to understand, I think, is that it's often, particularly in crystal methamphetamine, it's often these comorbidities that will prompt treatment seeking. So people are prepared to seek treatment around, for mood or anxiety problems, or maybe for trauma related issues, and then they're more willing to accept intervention around those issues than perhaps they might be at the beginning. So I think it's important for mental health services to be aware, and mental health practitioners to be aware, that it could be a group of people coming and presenting across your doorstep who are looking for some help to alleviate what I think a lot of people will consider to be the reasons why they might be using crystal methamphetamine.
Mm-hmm. Shalini, have you had much experience with comorbidities in your work?
Yeah, I think, Francis has mentioned sort of anxiety and depression being really key, and I think that's a lot of people might start off with those problems and use them to help with that. But I think also we see the converse too. People have ended up experiencing those problems as a result of long-term use, so both sides of the spectrum. But I think the other really common symptom is psychotic symptoms, where people who might be using might develop difficulties with hallucinations or agitation or suspiciousness in the context of use. It certainly doesn't happen for everyone, but it happens for a substantial minority of people, and for some people that can be severe enough that they might need to go into a hospital or an emergency department. And I think, as Francis pointed out, it's often sometimes a comorbidity that brings a person to treatment, and I think that's a comorbidity that definitely brings people to mental health treatment in particular, and acute healthcare, like an ambulances and emergency departments. And I guess that's a space that people can kind of start to talk about how to actually look at the use itself, if that's related to psychotic symptoms.
Do you think that people feel more comfortable talking about mental health issues rather than alcohol and other drug issues, or is it concerns that they will be, judged or received poorly by health professionals if they don't come seeking, treatment specifically for their use of drugs?
Absolutely. I think we'll all probably chime in on this one, but I think, there's certainly a very systematic and entrenched stigma in terms of drug and alcohol use, and I think methamphetamine in particular has had a lot of in-your-face media in the last little while, and I think that's really contributed again to kind of impacting on people wanting to seek treatment or not.
I completely agree, Shalini. I think particularly the way that the public views crystal meth use is really through that filtered eye of the media and, the emergency department reports and the epidemic proportions of the drug. And I think that creates a lot of stigma around admitting that that's an issue for you, that you need to seek help for. And I also think that people, particularly using crystal methamphetamine, might not identify themselves in the same framework as, what they might think a person using drugs, like heroin or the other sorts of drugs that they might think ends up in an alcohol and other drug use service. So they kind of see themselves as a little bit different from typical or stereotypical person who might go and access those treatments. So I think stigma is really important. In the early 2000s, when I was talking in the webinar about the psychosocial treatment intervention, the randomised control trial that Amanda Baker led with Nicole Lee and I was working on a while ago, we actually were recruiting people who had depression as well as amphetamine use at that time. And it was actually the depression-focused marketing and recruitment strategies that worked better at bringing people into the study. And when they got in, people would say to us, I'm much happier to admit that I've got a depression than I am to an amphetamine use problem. So we've got a long way to go in trying to encourage that, not open-minded, but that accepting that people are still humans, even though they do things that we might not agree with, and they're just as much in need of our help and attention as other people.
Yeah, wow. So, it does sound like we really need to do some work on the stigma and shame in this space. Especially if it's stopping people from seeking help. So something I think that you mentioned, Francis, was about trauma and somehow that is linked into people developing dependence. Is that correct? And if so, are there any treatments that are focused on trauma-informed care?
I think that's a really important question, and certainly a lot of the work that's being done in this area is coming out of the Matilda Centre, led by Associate Professor Kath Mills, who's doing a lot of work in integrating treatments for PT, posttraumatic stress disorder and trauma and alcohol and other drug use. I think out of a really growing recognition that it is early childhood trauma, but also exposure to traumatic events and incidents that can often lead a person to considering alcohol or other drugs, including crystal methamphetamine, as a way to try to help manage some of those experiences. People are really doing the best that they can in trying to cope with trauma and so forth, and so that's why we often see them we sometimes see them turning to things like alcohol or other substances, just to help them, I guess, get a bit of space or to feel good and those sorts of things. So I think in any kind of consideration of the management of crystal meth use or any other drug use particularly, we need to really take some time to understand what's brought the person to seek treatment at that particular point in time, and actually using trauma-informed care, but also designing an intervention that can address a lot of those other factors in addition to just the crystal methamphetamine use. So there is a huge trauma-informed care movement, which I support, and I think we need to be encouraging more of, but it's also in the context of actually understanding the person who's sitting in front of us needing treatment.
Okay, that's really interesting, and it sounds quite complex, but hopefully we'll see some great new research in the field. So another factor I think that you mentioned in your talk, Martin, was about genetics, and as someone who has a PhD in genetics, I was wondering if you could talk about, are those genetics always a risk factor for developing dependence, or can they also be a protective factor?
I think the answer to that is basically it's the same, because it's all part of a spectrum. And the mere fact that you see 4 different faces on the screen there tells you that even though we all have exactly the same genes, we do different things with our genes. And that's why we look differently and we behave differently. We do have the same genes, but they can have small variations. That means that the gene isn't used in the same manner. It's not translated into proteins as effectively or as rapidly, and that may make a system more or less vulnerable to external factors, including drugs of abuse. So that can mean that your system is, your dopamine system or one of those many other systems in the brain is already primed to a certain extent to hyper-respond or to change from normal function into a damaged function, if you like, as seen is in addiction. Whereas for other people, it may take a lot longer, a lot more of the drug or other circumstances to get to that stage. So yes, certain versions of genes can make you more vulnerable, but they can also protect you. The big question is, of course, which genes are they? We have many thousands of genes, and I wish it was as simple to say, oh, I've got that version of the gene, and that's why I'm going to be very at high risk of having drug dependence. We know nothing like that. We don't have a single candidate where we can say, look out, you are blah, blah, blah plus, and therefore you should stay well away from any stimulants because you might get addicted really quickly. Or, and this is of course the $1 million question, you've got BBB minus, and therefore you can take as much methamphetamine as you like and you'll never get addicted. It's never going to be like that, but we don't even have a clue which of those genes that might be. And obviously that's why very basic research into brain function, into the role of genes in the regulation of systems like affected by methamphetamine is very much needed. And this will also open the way for new medication, because you can then see, for example, which person would benefit most from particular kinds of medication. You might even predict that certain people would not benefit from one medication, but might benefit from another. And that's a long way to go, but that is why the combination of clinical and preclinical research is necessary, and hopefully one day we will get to the answer.
Yeah, I mean, that would be amazing, especially, you know, if we could tailor treatment specifically to help people with their comorbidities and their genetics. I mean, That would be fantastic. Frances, is there something you'd like to add to that?
Only to say that it's not pie in the sky thinking, because we've seen these models work really well in cancer. And so now for breast cancer, you can test for a special, specific genotype, and then from that you get your chemotherapy prescribed or applied with precision, or that you're not going to benefit from that particular type of chemotherapy. So it's actually not that far off, and we just need some more funding and some more research dollars to be able to take what we've learned in other areas and apply it to this really important issue.
Yeah, well, hopefully we see that funding come through, and Martin, you keep going with your preclinical research.
Thank you.
So I'm just going to quickly ask two last minute, I hope, short fire questions. First one is, how important are family and friends to the recovery process? Frances, because I know that you mentioned this friends and family support program that you have developed to support family and friends, but I mean, how integral is it? Like, should they be involved in someone's recovery, or is it best for them to take a step back?
Oh, this is such a, it's not a quick answer. I think it's a really important question though. So the short answer is they're very important for a number of reasons. And I think particularly the way that our health systems are set up at the moment, it's often family members particularly, or close friends who I guess are responsible for more of the round-the-clock care of people who are using crystal methamphetamine, certainly in the lead up to them seeking treatment, but also potentially supporting them through their recovery and thereafter. So I think we can't ignore both the impact that has on family members and friends particularly, but also the knowledge and the lived experience and that real-time, real-world reflection that they can often have on a person's situation as they go through the various phases of their journey with crystal methamphetamine. Whether they should be incorporated into the same treatment regime or planning for a person who is seeking help for crystal methamphetamine, I'm not sure. I think that's probably a very individual question, a very individual issue. Sometimes it can be very, very helpful. Other times there's a lot of pain and hurt on both sides, on all sides, especially in the early phases, for that to be helpful. But I think it's certainly a discussion and a conversation that needs to be had when a practitioner or a service provider is assessing or seeking to treat or work with a person who's using crystal methamphetamine. It's who's around in the social group, in the care circle, that might be helpful in terms of incorporating them into treatment and recovery plans, but also respecting that might not also be what's desired on all around. But also I think then separately to the understanding that in terms of prevention and early intervention, that the families themselves will be at very high risk for developing their own mental health concerns and other sorts of impacts as a function of having crystal meth come into the family. So we can't ignore them as a very needy group who are also worthy and in need of support for their own experience.
Yeah. And it's great that you've developed the family and friends support program specifically for families who have been affected by crystal methamphetamine and also friends. And there's also the family drug support, and they do great work. So one quick last question is that ice use has been found to be quite high in rural and regional areas compared to metropolitan cities. So one of the questions we had was, are some of the treatments that we talked about, specifically the psychosocial ones, available in rural areas? And is there anything that we could be doing better to support people in rural and remote areas who are having difficulties with crystal methamphetamine? So, Frances, would you like to take that one?
I absolutely would, and I think that's why technology has had such a transformative role in what we do, at least psychosocially, not only in this area of crystal methamphetamine, but broadly in mental health and substance use as well, in that we can actually take treatments that have worked in our clinical trials into real-world settings. So certainly the Breaking the Ice intervention and the Family and Friends Support Program are both freely available to anybody in Australia who has a smartphone or access to the internet. And increasingly, we know that we're finding that although the National Broadband Network probably isn't as reliable as we need it to be in all areas of the country, there are often places where we can go and access the internet if we want to. I know that Police Citizens Youth Club and other kinds of libraries and other public places will often have access to Wi-Fi for people who need it and can't afford their own, or maybe who don't want to use their data up on accessing these sorts of treatments. And we've specifically designed both those psychosocial interventions for a person using crystal methamphetamine and their family and friends, so that they are very low burden on data plans. So most of those publicly available Wi-Fi access spots will be enough to run and run through these programs. So hopefully that means, yes, that in those regional, very remote areas where we know that crystal methamphetamine use is higher than other areas of our country, that at the same time people will have access to those online treatments, at least that we've shown that trials are.
Yeah, no, that's great. And we're so lucky that the internet is allowing us to get out these treatment options around the country. So thank you so much, Martin and Francis and Shalini, for your time. It's been fantastic to not only hear your fantastic presentations, but also have you along today to answer some of those really important questions that people have about treatment options for ice dependence. So we will be holding more webinars and putting new resources on the Cracks in the Ice website throughout the year. So I would encourage any attendees to subscribe to our mailing list to receive future updates. And finally, I'd like to thank you all for joining us, and I hope you all have a wonderful day. Thank you again, Martin, Francis, Shalini.
Thank you.
Thanks.
Cheers. Bye.